Hello, my name is Kent Dickerson, and in this video I'm going to talk about health information exchanges. I'm going to give you a brief overview of what health information exchanges are. We'll discuss federal considerations leading to electronic health records and subsequent health information exchanges, as well as state considerations and implications for health information exchanges, also known as HIEs. Towards the end of this video, we'll discuss advancing and implementing HIEs, specifically to the state of North Carolina, and potential ways to move HIEs forward. Before we begin, I have to give a disclaimer that I'm not an expert in HIE. So hopefully by the end of this video, we will have met the objectives and you'll know more about HIE, and maybe you'd like to open up a dialogue and comment to the video. So let's get started. Just as it sounds, the Health Information Exchange is based on the idea that people's health information can seamlessly be shared between healthcare organizations that are in a community or a region. Quite simply, this means an emergency room provider will be able to access a person's health information from a recent doctor visit. Valuable information such as allergies, past medical history, and current medications are readily available. This is demonstrated on the chart. This represents your primary care provider. As you go in for your checkup or other office visit, there is an electronic health record which stores your health information. Part of that EHR includes radiology, medications and pharmacy, lab data, and vital signs, which automatically populate into the health record. The provider uses the EHR to order x-rays or labs, and when the results are completed, x-ray and lab talks to the EHR, and they're automatically populated for the provider to review and make their decision. This represents the hospital, which also has an electronic health record. It operates under the same premise of the primary care physician, where the doctor uses the EHR to order tests and then lab, x-ray, and other systems which transfer health results back to the EHR. Of course, the same is true for the specialist with their diagnostic testing and their reporting results. As larger healthcare organizations purchase more and more clinics and offices, the parent organization generally changes the EHR system to their own. This provides streamlined communication between offices and hospitals, thereby making the entire process interoperable. An issue arises when a person who lives outside of the region goes to their primary care physician. Their primary care physician may want them to see a specialist, such as a cardiologist or orthopedic surgeon. The specialist's office, EHR, is not affiliated with the hospital record. However, the surgeon schedules the surgery at the hospital. When the patient goes to the hospital for their surgery, there is a substantial portion of time asking about the patient, their medical history, medications, allergies, etc. If the patient is feeling bad, they may or may not give accurate information. As seen in this chart, this is where health information exchanges come in. The HIE gathers patient data and puts it into a database, regardless of the geographic region. That database is then made accessible to the healthcare organizations, which are part of the Health Information Exchange. As you can see, a patient from this region may seek health services from a different region. Due to the Health Information Exchange, the physicians from both regions would have access to patients' records and be able to communicate efficiently to make timely decisions with little delay in treatment. Therefore, there are many benefits of having an HIE. They include continuity of care, which is the major benefit, reducing redundant tests, which will decrease overall healthcare costs. It also can provide big data to track and trend data for quality improvement and implementation of evidence-based practice protocols. It will also allow healthcare providers and offices to keep their electronic health record instead of having to convert to one standardized EHR, or electronic health record. This means that HIE provides a basic level of interoperability between many different types of healthcare software platforms. Turning toward federal considerations, the groundwork for HIEs actually started in 1996 with the Health Insurance Portability and Accountability Act. This is also known as the Privacy Law. It has guidelines for protecting patients' healthcare information and how it can be shared for reimbursement purposes. In 1999, the Institutes of Medicine published a report, To Err is Human, and in 2001, they followed up with Crossing the Quality Chasm. Essentially, these reports called for healthcare entities to focus on error prevention and ways to improve quality healthcare, both of which health informatics and electronic health records can greatly impact. In 2005, President Bush introduced his Health Information Technology Plan, followed up in 2009 as part of the Affordable Care Act. The Health Information Technology for Economic and Clinical Health Act, which is also known as HITECH, led to the Office of the National Coordinator for Health Information Technology, also known as the ONC. The ONC provides the U.S. Department of Health and Human Services with the authority to advance policies related to quality, safety, and health information exchange across the nation. Furthermore, the Office of the National Coordinator is responsible for implementing provisions to Public Law 114-255, and this is better known as the 21st Century Cures Act. This was passed in 2016. Those provisions advances interoperability, clarifies HIPAA privacy rules, as well as other duties. Looking at state considerations for North Carolina, it has been very active in legislation for health information exchanges. In 2015 and 17, this law required providers receiving reimbursement from North Carolina Medicaid and Health Choice, where they had to join the North Carolina Health Information Exchange Network. This North Carolina statute, NCGS 90-414.7, this is where the North Carolina Health Information Exchange Network was to have oversight by the North Carolina Health Information Exchange Authority. The North Carolina Health Information Exchange Authority operates NC Health Connects, which is the health information exchange for the state of North Carolina. These statutes here require that hospitals, physicians and physician assistants, and nurse practitioners who receive North Carolina Medicare and Medicaid to be a part of the North Carolina Health Connects as of June 1st of this year. So this was a recent change. This law, SL 2015-245, also addresses prepaid health plans and managed care organizations to be signed on to NC Health Connects by the year 2020. All of this legislation was enacted to enroll as many organizations, providers, and North Carolina residents as possible into the NC Health Connects. There are quite a few considerations looking at implementing or advancing the health information exchange in North Carolina. First, as seen previously, continued legislation will be the major catalyst for implementing the HIE. Incentives for compliance in the forms of tax rebates or even penalties for non-compliance will advance HIE goals. Doctorally prepared nurses and other health professionals will have numerous opportunities for projects related to the HIE. They will need to utilize the big data which will be generated to disseminate best practices. Therefore, early and frequent research studies will advance the HIE agenda. The next consideration is consumer incentives. Much like federal and state incentives, health insurance companies could provide monetary or cost reduction incentives to their consumers if they opt in to the NC Health Connects. Other ways to advance and implement HIEs is to increase the interoperability between regions and states. For instance, creating an overall health information exchange for regional health information exchanges, and this would be a federal push. North Carolina Health Connects needs to address concerns of breaches or privacy and ethics to the public. There should be a concerted marketing campaign explaining the health exchange as well as the ability for the North Carolina resident to opt out of the exchange if they so choose. Currently, the resident has to sign a form and turn in to NC Health Connects should they not want their information shared in the health information exchange. This marketing program to the residents of North Carolina should include radio and TV ads. The more information given regarding the NC Health Connects, the more people will be aware of its capabilities. These demonstrate just a few ways the North Carolina Health Connects could be implemented and advanced in the state. By now, you should have a general knowledge of what a health information exchange is, federal and state considerations which have led to the NC Health Connects program, and ideas for advancing and implementing the health information exchange throughout the state. I sincerely hope I have generated some talking points in regards to health information exchanges and have given the basis to start a dialogue. Therefore, if you have comments or questions or suggestions, you can do so directly under the video. Here are a few references which helped me prepare this presentation. Thank you, and I hope you have a great day.